Günaydın sevgili arkadaşlar. Yoğun bir günün ardından ikinci günde biraz hafif dökülmeler başladı ama zannediyorum dolduracağız birazdan. Şu anki oturumumuz nörojenik alt üriner sistem işlev bozuklukları. Çok kıymetli 4 konuşmacımız var. Ve soru cevaplarla bu oturumumuzu da sonlandıracağız. Ben ilk olarak EAU ve European Section of Female and Functional Urology Section Başkanı, iyi dostumuz ve bizim kongrelerimizin en büyük destekçisi sevgili Francisco Cruz'u davet ediyorum. Kendisi nörojenik üriner inkontinansın yönetimi konusunda konuşmasını yapacak.
Thank you very much for the invitation as full chairman, something that will finish in next April. I will finish my 8 years of chairmanship in the section, and someone else will be elected and will follow the work, which is essential in order to maintain functional urology inside the European Association of Urology and, of course, in connection with other societies. Well, today the idea is to talk about the management of neurogenic urinary incontinence, and I decided to start with this classical drawing from Claire Fuller, and it shows clearly that there are two types of incontinence. One associated with neurogenic detrusor overactivity, which is typical from the supraspinal lesions or from the spinal lesions above the sacrospinal cord segments, eventually associated with detrusor sphincter dyssynergia. And then there are the incontinence associated with the sacral spinal cord lesions or with peripheral lesions affecting the nerves that go to the external urethral sphincter, and that will cause stress urinary incontinence or overflow incontinence. So starting for neurogenic detrusor overactivity incontinence, clean intermittent catheterization in many patients is critical. We don't have to spend much time on that. Anticholinergic medication is also extremely important. We don't have one single drug that is better than the others, but we might need to use them in higher doses, and these might have cognitive problems for elderly patients, something that we might discuss later on. We clearly need data from mirabegron. Mirabegron is being tested in small cohorts. Apparently, it's very effective in treating neurogenic detrusor overactivity, incontinence in multiple sclerosis, Parkinson, even in spinal cord disease patients. But it is unclear the severity of the cases that were included in these studies, and that is something that clearly we need large randomized clinical trials in order to check the efficacy of mirabegron. Botulinum toxin so remains an important tool for the treatment, and these are the data for Botox. Data that are well known for 200 units for spinal cord injury and MS patients. The results are similar whatever we use for MS or for spinal cord injured patients in terms of improvement of incontinence. And the percentage of patients that are continent at week 6 during 7 days in a 7-day bladder diary is about 37%, which is extremely good, and also a decrease in the detrusor pressure, so protecting the upper urinary tract. Of course, the problem of using botulinum toxin in MS patients that void spontaneously is the risk, using 200 units, is the risk of urinary retention. In the initial study, the urinary retention occurred in almost 1/4 of the patients. So in patients with multiple sclerosis, that is not very, very agreeable. It's difficult to manage. And so a randomized clinical trial was conducted with 100 units that proved also a very good efficacy, and now is the ideal dose to start in MS patients. What is new in the area of botulinum toxin is that botulinum toxin type A or Dysport received approval from EMA after the content 1 and content 2 pool data. So with 600 or 800 units of botulinum toxin, the reduction in episodes of urinary incontinence is much superior to that of placebo. And on the right side, the percentage of patients that achieve 75% or 100% of continence with 600 or with 800 units of botulinum toxin is excellent and very similar to the one we had seen with botulinum toxin. Also, involuntary detrusor contractions disappear in 50% of the patients if we perform urodynamic studies at week 6, and the detrusor pressure decreases, so also protecting the upper urinary tract. So something that was already quite evident from our practice or from those that were using off-label botulinum toxin is now demonstrated by these phase 3 trials. And because the design of the phase 3 trials for Botox and Dysport were very similar, that gave us the opportunity to compare the two in terms of efficiency, in terms of capacity of reducing the number of incontinence episodes or achieving 100% of reduction of incontinence episodes, so full dryness. And the conclusion is that the two toxins provide exactly the same outcome. The small difference is that one can see probably have no clinical meaning and might be the result of the doses that we have in the vials available commercially. There are a few studies, very few studies comparing antimuscarinic drugs with botulinum toxin, because the rule is botulinum toxin is indicated if antimuscarinic drugs are not effective, but this study clearly demonstrated that botulinum toxin is much more effective than high doses of antimuscarinics to improve continence, to increase bladder capacity, and to decrease the detrusor pressure. Which means that probably we should start earlier the treatment with botulinum toxin in the patients that are at higher risk of upper urinary tract deterioration, because clearly the results with botulinum toxin are much better. Of course, botulinum toxin is not the end of the line. Some patients might still prefer to have bladder augmentation, and if the renal function is adequate, bladder augmentation is an excellent option, but we should inform the patients that they will need clean intermittent catheterization and, of course, vigilance of the electrolyte balance, because it might be changed due to the use of ileum. Well, the Brindley stimulator was something very interesting if the posterior root section was not necessary. In fact, continence was described in up to 100% of the patients with good bladder capacity, with low post-void residuals, low incidence of urinary tract infections. It could even improve erections and evacuation of the bowel, but the problem is that in patients that still have sensation in the perineal area, the section of the posterior, sacral posterior roots decreases or abolish these sensations, and patients don't want. So we need to find a better way to stop the activity of the posterior roots that we still don't have. Sacral neuromodulation for the treatment of neurogenic detrusor overactivity. Eventually, we might have the comments from Professor Sievert, because he is the author of this meta-analysis. The results, well, the data obtained from this meta-analysis are from a small number of trials that included more than 4 patients, but the success rate that was indicated is 84%, which is excellent, and very few adverse events. So sacral neuromodulation might be an excellent alternative for the treatment of neurogenic detrusor overactivity. And as we were discussing in the interval, now what we need to find is the correct indications for which are the ideal patients that might benefit from sacral neuromodulation. Probably not all of them, but which are the ideal patients for sacral neuromodulation. And same for posterior tibial nerve stimulation, particularly now that the subcutaneous implants are available. And for multiple sclerosis, this study from Italy shows that is clearly superior to behavioral therapy, and the number of urgency episodes, incontinence episodes, micturations per day improves substantially with PTNS. So again, we need larger studies. This study has only 21 patients, so we need larger studies. Moving to stress urinary incontinence. Here, the information that we have is very much reduced, also because the number of patients with stress urinary incontinence is less than the patients with incontinence due to neurogenic detrusor overactivity. And of course, autologous sling is an option. It's an option if they are placed in bladder neck, but we have to be sure that the bladder has good characteristics, because we don't want to put an autologous sling in a patient that has a small bladder capacity and a bladder with low compliance. That might eventually develop in the long term, and so this requires vigilance. Moreover, some of these patients still need CIC to empty the bladder, and so the autologous sling might be a problem and might create problems in terms of introducing the catheter. But the continence that is shown in the ICI 2023 review indicates numbers between 60 and 90%. Synthetic suburethral slings are now being tested in women and in men, and in women even the single incision slings have been tested. In men, the male slings that are used for post-prostatectomy incontinence. Again, this is the beginning of the research, small cohorts. The initial results seem promising, but we need larger cohorts and long-term follow-up because of the risk of erosions associated with this type of synthetic slings in these neurogenic patients. And artificial urinary sphincters, of course, they are a good alternative for the treatment, an excellent alternative, actually, for the treatment of stress urinary incontinence. And the results, you can see, in terms of continence, are excellent, 60%, 80%. So the results are actually very good, both in men and in women. Problem in this group of the patients is that it's not exactly the same as non-neurogenic patients. So the risk of erosions, the risk of infections is much higher, and many of these patients still require clean intermittent catheterization with the artificial urinary sphincter in position. And so that increases the risk of erosions of the urethra. And so I make a summary of the data that were presented in the review in the ICI book 2023. And so first, the risk of infection is higher than in post-prostatectomy population. Manual dexterity is important to be checked before placing the artificial urinary sphincter, because it is necessary to manipulate the pump and eventually to do CIC. The cuff, if in men it is not clear where it should be placed. The easiest place is, of course, the bulbar urethra, but the risks of erosion are higher to place in the apex of the prostate or around the bladder neck is much more difficult, and eventually with robotic surgery using the same approach as in women might be a solution. In women, clearly is in the bladder neck, but again, although the results in non-urogenic patients are much better, here the problem is the risk of erosions and infections. These are a particular group of patients that have higher risk of erosions and infections. And I think that we should not go for the treatment of stress urinary incontinence in urogenic patients before confirming that the bladder has good capacity and good compliance, because otherwise we can put at risk the upper urinary tract. So to conclude, Mr. Chairman, incontinence in neurogenic patients can be caused by neurogenic detrusor overactivity or by weakness of the urethral sphincter. The most important innovation in terms of neurogenic detrusor overactivity induced incontinence is the approval by the European Medical Agency of abobutylinotoxin A, and clearly the technical improvements associated with sacral neuromodulation, in particular the fact that nowadays the stimulators are MRI compatible and can be rechargeable through the skin. PTNS requires, of course, more studies, and the treatment of stress incontinence with autologous or synthetic slings or by artificial urinary sphincter is promising, but we need larger studies and longer follow-ups. Thank you very much for your attention and the invitation.
Francisco, thanks indeed for this excellent presentation. Salondan soru ya da katkı var mı? Buyurun Cüneyt Hocam.
Çok teşekkür ediyoruz sunumunuz için. Her zamanki gibi mükemmeldi. Ben merak ettiğim bir şey, kendi tıp pratiğinizde nörojel mesaneli hastalarda botulinum toksin enjeksiyonunu yaptıktan sonra İkinci kez gerekirse ne kadar bekliyorsunuz? O klasik 3 ay sizde de var mı, yoksa bu değişiyor mu?
We still wait for 3 months. That is a general rule. I am not sure if it is a correct one, but that is the general rule. Clearly, what is being discussed, and I had the opportunity to review one paper, we never get 100% of good results after the injection. We don't know why, but we don't have 100% of good results. And so the fact that we don't have one good result, that should not mean that we should not offer 3 months later another treatment cycle to that patient, because that patient might respond well after a second treatment.
Başka soru yok. Çok teşekkür ederiz yeniden bu konuşma için.